So glaucoma management is more of an art than a science. The introduction of several new classes of glaucoma medication and the completion of many large randomized clinical trials have not changed this fact, and while we now have a better choices when initiating the glaucoma therapy relative to our uh, preceders, the principle of glaucoma therapy have not yet changed. The reduction in rate of ganglion cell or delaying the progression of the visual field is the aim of glaucoma treatment, and we also have to maintain the quality of life. We know that the retinal ganglion cell loss is age related, and this loss is 10 times greater in the glaucomatous eyes compared to the normal, and what we have to do is to bring up the line which is going down by treating these patients. The various studies, particularly AG study, has demonstrated that lowering the intraocular pressure is associated with the reduction in the progression of visual field defect, and the field loss was lowest when the patient was followed up with the IOP below 18 millimeter at 100% of the visits, or the mean IOP was 12. And so did the old study has said that by lowering the intraocular pressure, conversion rate to the glaucoma is lower. So the lowering is intraocular pressure is the only option available to us, and how low is the better? Dr. Narang said that it could be even lower. So that brings the concept of target intraocular pressure, which is a personalized, customized, and a dynamic thing. It prevents the IOP, which prevents the further loss without losing the quality of life, is the target pressure that we have to. It's not a magic number 1 or 20 or 18, but it's a range, and it is already been discussed by previous speaker how we decide on what should be the target range. Other consideration for that is not only the severity of the disease but comorbidity, what is the life expectancy of this patient, and most importantly family history and the cost and risk factors involved. Lowering IOP lowering with monotherapy is ideal treatment. However, it may not be enough in all the patients because of maybe a patient is non-compliance, there is a risk of adverse event, and the Coates collaborative initial glaucoma treatment study has shown that at the end of 2 years, 75% or more patients require 2 drugs or more medications. Same is with the O study. So we know that monotherapy is not enough for many patients over a period of time. So what should be the appropriate action of the patients who did not respond adequately to the monotherapy? Should we switch to the another molecule or to add another IOP lowering medication? So according to EGS guideline, if first choice monotherapy is ineffective in lowering intraocular pressure less than 15% from the baseline or is not well tolerated, you have to switch. If first choice monotherapy is partially effective or efficacy is more than 15% in lowering IOP but does not achieve the target pressure, you add one more medication. Now how do we select a second therapy? It depends upon the primary therapy that patient is using, and most of the patients nowadays we are putting them on PG analog or beta blocker. So once you have achieved the IOP reduction that you have expected from the primary agent, if you have not achieved, there is no point in switching to the same group of or same class of the drug and try to another agent from a different class of the drug. This is a classic example of a mild primary open angle glaucoma. IOP, baseline IOP was 20 and 21, and we selected to use beta blocker in this particular patient. After 1 month follow up, the right eye pressure was 19 and left eye was 20. So the reduction of 15% is not there. So this drug is either not effective or there is a poor compliance. So what should we switch to? So the 3 molecules that are shown here, I prefer to use PG analog because this patient had a very low IOP to start with, 20 and 21, and PG analog can lower with a good compliance, once a day dose, less systemic side effect, and it can lower the IOP below episcleral venous plexus. Another example of angle closure glaucoma with a bronchial asthma, and this patient was started on pilocarpine till we did the YAG PI, and we continue the pilocarpine subsequently, and the gonioscopy showed opening up of the angle. The target IOP was achieved, but here the problem was that with the discomfort and the headache with the pilocarpine. So she wanted to change the medication. So we need to switch the drug. So this is the beta blocker is out of question as patient has a bronchial asthma, known case, and these are the drugs that one can choose to. So when the monotherapy initially is achieved the IOP reduction you expected but does not bring the patient to target pressure, the best option is to select another group of drug, and it depends on what is the first drug that is already been chosen depending upon the safety, efficacy, convenience, tolerability. This all is applicable when you want to add the second molecule. Select the one which is most likely to lower IOP to the target range and choose the cheaper and better tolerated agent according to the patient needs. Now this is a very important pearl, that efficacy of the same molecule as adjunct is different than when it is used as a monotherapy. For example, beta blocker as a monotherapy lowers IOP by 5 to 6 millimeter of mercury, but when it is added to PG analog as a adjunct, the supplementary reduction is only 1 to 2 millimeter of mercury. We have to also see that the patient is, remember, patient is asymptomatic till we start the treatment. So we have to select something which has a less side effects, convenient dosing, good bottle quality, and of course we have to think about the cost of the drug. And what to select? Always select the complementary mechanism of the two molecules that you have, and the fixed drug combination is a better options. Now preferred agent as a primary therapy, as I said initially, is a PG analog in most of the cases unless it is contraindicated, because it is good as a lowering the intraocular pressure. Efficacy is about 25 to 30%. It also has a diurnal and nocturnal IOP lowering effect, and it lasts beyond even 24 hours and well tolerated systemically. Now usually the beta blocker is added to all the combinations, but it is not necessarily the best adjunctive agent when used in patients already using the PG analog. The topical carbonic anhydrase inhibitor various trial has shown that has a beneficial adjunctive effect to the PG analog. So choose the agent depends on this as I have said, various factors. So to conclude, there is no one size fit all algorithm. You have to customize the treatment according to your patient's need. Remember, IOP lowering must follow 24-hour circadian rhythm, and also look at the comorbidity that patient has. Selection is incomplete until you have performed a therapeutic trial in your patient.
Thank you, ma'am. Thank you, always finishing in time.